Body and bone. It's good. Next one is osteomyelitis, histopathology. Osteomyelitis is an inflammatory infection of the bone and bone marrow. Histological features vary by phase. Acute cases show dense neutrophilic infiltrates and bone necrosis, empty osteocyte lacunae. Chronic cases are characterized by lymphocytes, plasma cells, fibrosis, and sequestra, dead bone fragments surrounded by new bone involucrum. Key histological features. Histopathological evaluation is the gold standard for diagnosing osteomyelitis, typically alongside bone cultures. Osseous changes, bone necrosis, empty lacunae. Osteocytes die due to localized ischemia from infection and inflammation, leaving empty spaces lacunae within the bone trabeculae. Sequestra, irregular, fragmented, and completely necrotic pieces of bone can break off, forming a sequestrum. Involucrum, in chronic stages, surviving fragments of the periosteum and endosteum may form a sheath of new reactive live bone involucrum enclosing the necrotic sequestrum. Inflammatory infiltrates. Acute osteomyelitis, marked by dense diffuse infiltrates of neutrophils, polymorphonuclear leukocytes, and fibrin exudate within the medullary cavity. It frequently forms microabscesses, clusters of more or equal to 5 granulocytes. Chronic osteomyelitis. The infiltrate shifts to mononuclear cells, predominantly lymphocytes, plasma cells, and macrophages or histiocytes. Granulation tissue forms alongside progressive fibrosis of the marrow space. The difference between acute and chronic osteomyelitis. Primary cells in acute neutrophils, in chronic lymphocytes, plasma cells, and macrophages. Bone appearance in acute viable osteocytes tough disrupted by microabscess. In chronic, dead bone, empty lacunae, often separated from new living bone. And marrow space in acute, edema, fibrin, and abscesses. In chronic fibrosis, granulation tissue, and neovascularization. Next is osteomyelitis, another slide of osteomyelitis. You can see sequestrum. Next is osteomalacia. Osteomalacia histology is characterized by a dangerous buildup of unmineralized bone matrix known as osteoid and a delayed mineralization process. While standard blood tests like measuring vitamin D levels often flag potential issues, a transiliac bone biopsy remains the gold standard for a definitive histological diagnosis. Core histological features, widened osteoid seams, the hallmark of the condition. In healthy bone, the thin layer of newly formed unmineralized osteoid is quickly calcified. In osteomalacia, the seams are notably widened and disorganized, generally measuring more than 12.5 micron or even more than less than 15 micron. or more than 15 micrometer in some criteria. Increase osteoid volume and thickness. The overall percentage of osteoid volume typically rises above 5% of total bone volume. Mineralization lag time. Time required for newly deposited bone matrix to mineralize is severely prolonged from a normal duration to more, more than 100 days. Tetracycline labeling. To accurately measure this lag time, patients are often given two doses of oral tetracycline several weeks apart before a biopsy. Because tetracycline binds to the calcification front, a pathologist can measure the distance between the two fluorescent bands to calculate the exact daily calcification rate. In the slide of osteomalacia. Next, Brody's abscess is the pathology. Brody's, so you can see Brody's abscess. Brody's abscess histopathologically is characterized by a localized central zone of liquefactive necrosis and pus, surrounded by a thick, reactive wall of fibrous granulation tissue and sclerotic bone. Here are microscopic views demonstrating the inflammatory changes, necrotic fragments, and bone remodeling typically seen in subacute or chronic osteomyelitis like a Brody's abscess. Key histopathological features. When analyzing a Brody's abscess specimen under a microscope, pathologists typically observe three distinct concentric layers. Central core. Central core contains necrotic debris, dead bone fragments sequestered, and a dense accumulation of polymorphonuclear leukocytes, neutrophils, forming pus. Inner wall, pyogenic membrane, a highly vascularized layer composed of granulation tissue, proliferating capillaries, lymphocytes, and plasma cells. Outer wall, a dense zone of fibrovascular tissue undergoing active bone remodeling, featuring osteoblast activity, laying down new bone involucrum alongside osteoclastic bone resorption. This is the steps. Next, tuberculosis of the bone is the pathology. Tuberculosis (TB) of the bone is diagnosed by a tissue sample. The defining microscopic feature is a caseating granuloma. This is a ball-like cluster of immune cells that walls off the bacteria. At the center is dead, cheese-like tissue, caseous necrosis. The classic features of bone TB on a microscope slide include granulomas. These are clusters of white blood cells. They include epithelial macrophages, large immune cells, and Langerhans giant cells, huge cells with many nuclei. Caseous necrosis. The center of the granuloma dies and looks like pink cheesy mush. Lymphocytic cuffing. Ring of smaller white blood cells around the granulomas. The tuberculosis of the bone system. You can see the granuloma. So today I have discussed some histopathology, pathology, pathology of some conditions of bone, including osteomyelitis, osteomalacia, and Brodys abscess, and lastly, uh, osteomyelitis, osteomalacia, Brodys abscess, and TB of both. Thank you for patient.